dysrhythmias that we have to know for the USMLE, which are pretty straightforward. Which types of acute pericarditis do we have to admit to the hospital and do further investigation, including sometimes procedures? Good. So Mary said it very well, non-viral, which is malignant especially. Be careful about uremic pericarditis, right? Uremic pericarditis means this person hasn't been dialyzed and has developed pericarditis from the uremia, and this is a medical emergency. They have to come in and dialyze this person acutely, right? So if you got a patient with end-stage renal disease, missed a couple dialysis sessions, and comes in and has a friction rub and stuff like that, you're in trouble, right? So uremic pericarditis needs further investigation and treatment. Malignant pericarditis needs further investigation and treatment, and so does the one associated with collagen vascular diseases. That needs treatment, needs corticosteroids, high doses of corticosteroids. The viral type, give them some NSAIDs, give them some aspirin, send them home. Okay? So when you get a case of acute pericarditis, you're looking for things that will say, okay, I'm pretty confident it's viral because I can't find cancer. This person doesn't have any symptoms and signs of cancer. This happened just over 3 days, and this person had a viral syndrome before, stuff like that. Then you say, okay, send them home. Okay? Everybody clear on that? All right, what are the causes of constrictive pericarditis, and what is the treatment? Remember porcelain heart. Radiation, TB, those are the big ones, right? And then what's the treatment? Right? You remove the pericardium, cardiectomy. Okay? Everybody okay with that? It's not an easy procedure, but it's life-saving. That gets only worse. All right, very good. Okay. EKG. All right, now you guys know this stuff. All right, I got to just tell you some stuff to keep in mind. All right, so the distance in a small box, 0.04 seconds. So when you look at the thick lines, 5 small boxes, it's 0.2 seconds. This 0.2 second is very important because a very important interval, the PR interval, should never, right here, the PR interval is a very important interval in dysrhythmias. The PR interval should never be more than these thick lines, 5 small boxes. 5 small boxes, 2 thick lines, right? It should never be more than 0.2 seconds. We're saying the same thing. Everybody okay with that? All right, number 2, right? When we look at an EKG, the first thing we look at is, does a QRS complex follow a P? Right? Every P should be followed by a QRS complex. And then when we look at the QRS complex, right, we look to make sure it's not broad. Right? So large, wide QRS complexes usually arise from the ventricles. All right, everybody remember that? If you have idioventricular pacing because the rest of your conduction system is blocked out, your nodes that drive your ventricles are in the ventricles, and this idioventricular pacing is very slow. They're slow and they don't use the normal conduction system, so your QRS complexes are very wide. If your QRS follows the sinus AV node, Purkinje fibers, those are fast pathways. So your QRS complex looks normal, slim, not wide. Right? Why does your SA node take over everybody else? Because it's faster than everybody else. Right? This is why if your driver is in the sinus node, it's 70, 80, something like that. If it's in the AV node, it's a little slower. And if it's in the ventricles, it's in the 30s and 40s. Right? Unless there's some kind of other conduction problem. Okay? Everybody clear about that? All right, these 5 small boxes, 0.2 seconds, very important. When you look for dysrhythmias, when they give you EKGs on the USMLE, you look at the PR interval and the QRS complex. Those are the first 3 things. PR interval, right? Does the QRS complex follow every P? And look at the QRS itself. We got to do that systematically. Those 3 things. And then there's a couple of other things we need to know. Okay, we'll talk about the other things, but those are the big 3. All right, so we got to know the rate. All right, you guys know this. You've done this. Okay, you pick a start, pick one QRS complex with a start, and if the next QRS complex is after 0.2 seconds, remember 5 small boxes, 2 thick lines, then the rate is 300. If it's 0.4 seconds, then it's 150, right? So you're following the thick lines here, right? 300, 150, 100, right? And this patient is at 75, right? So we've got to know these numbers. 300, 150, 100, 75, 60, 50, right? Everybody okay with that? We got to get the rate. All right, what if the rate is irregular? What if we have an irregular rhythm? Okay, they give you, on the bottom of the EKG, they give you a continuous strip. Look for the 2 red lines. The 2 red lines, right, see here? Those are 3-second markers. So what you do is you count the QRS complexes in a 6-second strip and multiply by 10. Right? So look at here. 1, 2, 3, 4, 5, 6, 7, 8, 9. Right? See that? Well, maybe even 10. I forgot the first one. Right? So this patient 10 times 10 is 100. Right? Everybody okay with that? So in AFib, atrial fibrillation, I can't do this, right? Because it's irregular, and it's irregularly irregular. So the QRS complexes are all over the place. So I could have a QRS complex here, right? And then the next one all the way down here. I can't use the 300, 150, 100 rule. I have to do the 6-second strip. Okay? Everybody okay with that? We have to be able to get the rate. Okay? All right, very good. All right, so normal sinus rhythm is a regular rhythm. Okay? Yeah, 3 seconds. Each one is 3 seconds. So from here to here is 3 seconds. Right? Okay. So 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 normal sinus rhythm is a regular rhythm, right? There's a marriage of the P waves with the QRS complexes. So QRS complexes follow every P wave. Just please ensure that every P wave is followed by a QRS complex. And another way to say this, that a QRS complex is preceded by a P wave. A lot of the dysrhythmias they show us, right, is missing a marriage of the P waves with the QRS complexes. So I'll show you a couple of examples. Okay? Everybody okay with that? All right, we'll talk about sinus rhythm in a little bit. All right, so PR interval, as I mentioned before, is very, very important in some types of blocks, right? The PR interval is the normal AV node slowing conduction down. This is part of the normal process to allow diastolic ventricular filling, right? A normal PR interval, right? You guys are going to remember what? It is never beyond 0.2 seconds, right? So look at here. Here's this box, right? And here's the second thick marker, right? The PR interval should never be more than 5 small boxes, 0.2 seconds. Everybody see that? All right. In this PR interval, you should see a couple of things. You should look for a couple of things that they're going to ask us on the USMLE. Number one, when you see the PR interval go like this into the QRS complex, right? So you don't really have any distance. It goes right into it, right? What is that called? That is called a delta wave. And that is part of the Wolff-Parkinson-White syndrome. This is what? The bundle of Kent, right? This is the alternative pathway. This is the fast pathway. This is why these people get tachyarrhythmias, right? Because there's no slowing from the AV node. It uses this quick pathway to bypass the regular AV nodal slowing. Okay? And then certain AV blocks. We'll talk about these. These are very important. Where the PR interval is increased. So what does PR interval increase mean? It is over 0.2 seconds. Okay, I don't remember seconds. So how many boxes is it? 5 small boxes, right? 2 thick lines. It's bigger than 5 small boxes. Okay, everybody remember that? Okay, very good. Okay, what else did we need to know? Okay, I told you guys yesterday. All right, so please be careful. They've asked what are the first changes in an acute MI. All right, so the first changes are not ST elevation. The first one is the peaked T waves right here. Okay? So be careful of that because they have a person with these tented peak waves. And then you guys and myself too, first thing we look for is what? Hyperkalemia. Right? It causes very similar looking T waves. These large tented T waves, peak T wave. That wasn't a choice. So the students were asking me, what else causes tented T waves? And the answer is, that's an MI. It's the earliest change. So there's two questions that they could have on the USMLE. They could give you the CKG and say, what is this associated with? Or they can ask, what are the first changes, earliest changes in an evolving acute MI? So before the ST elevation, okay, you get the peak T wave. Actually, Q waves occur after the ST elevation, right? And sometimes if you open up the vessel early, patients don't get Q waves, right? Those are people we used to see a lot of before we realized that we really have to do our best to open up the vessels and restore perfusion. Usually Q waves means there's damage there, sometimes permanent damage. Okay? Everybody okay with that? Okay, very good. So this is a good slide for you guys to remember, right? You don't have to know all the details here, right? But you have to know that peak T waves come first, then ST elevation, then the Q waves, and then eventually T wave inversion. Okay? All right, so look at this. Sinus bradycardia, okay? Ventricular complex are normal. The rate is regular and less than 60. Okay, so look at here. Let's go number one, right? Let's look at the rate here. What's the rate? So pick one right on the line here, right here. Okay? Everybody see that? So this is 300, right? This is 150. This is 100, right? Everybody see that? Now I'm kind of lost here. Okay? This is 75. This is 60, right? This is 50, right? So you guys are right. This is like 45 or something like that, right? 48, okay? Everybody okay with that? All right, so that's number one, right? Say about 48 to 50, okay? All right, but you got it around that, right? Okay, number two now, all right, we have to look at the QRS P complexes and the PR interval. Okay, so pick one that's easy to look at. All right, so let's take this one. Okay, PQRS, right? All right, it looks normal. Does it look less than 0.2 seconds? See, here's your P right there, right? Here's your QRS right here. Okay, yeah, definitely less than 0.2. All right, so okay, so we're good there. Okay, number two, how about the QRS complex? Does it look normal or does it look wide? Looks pretty slim to me, right? Looks pretty normal. All right, check there. Looks narrow. And then the last thing here is, does a QRS follow every P? Right? PQRS. Right? PQRS. PQRS. Same thing here. Okay, it's not the best EKG, but I think you could see it. Right? This is sinus bradycardia. Right? The PR interval is not increased. A QRS complex follows every P. QRS complex looks normal. Right? It's just a slow heart rate. So what causes this? All right, so look at this. What's the most common one that causes sinus bradycardia? maybe sleeping. All right, you guys ever see young people with heart rates in the 50s? And then you ask them, that's right. Rudy says, athletic, athletes. So I ask him, what do you do? Oh, I'm a marathon swimmer. I'm a marathon runner. Stuff like this. Okay? And then listen, don't forget hypothyroidism. All right? So the only thing I check for here is hypothyroidism. And then I always check for medication. Beta blockers and stuff like that. Calcium channel blockers. Right? Those are the two most common ones. Okay? And then there's some other ones, like depression of the sinus node, right? Sometimes from ischemia, and then sometimes hypothermia. But check these things here, right? Athletes, hypothyroidism, and if they're taking medications, right? So be careful. Some people take some herbal stuff that have properties like beta blockers or calcium channel blockers. There's really nothing to do here. Okay, usually doesn't demand treatment. Okay, so sinus bradycardia, right, is usually a heart rate of less than 60. The rhythm is regular, right? There's a P wave before each QRS. And remember this, right? Look at this. The PR interval is less than 0.2. Be careful because you're going to see some other types of dysrhythmias, right, where the PR interval is over zero point 0.2. That's not sinus bradycardia. Okay, then lastly, the QRS complex looks non-white, right? That's usually like about 3 small boxes. Okay, 3, maybe at the most 4. Okay, okay. So now let's talk about heart blocks. So heart blocks can occur at the AV node or sometimes infranodal location. So what is blocked is normal conductance of the P wave down to the ventricles. Okay? All right, who knows what a first degree AV block is? So we're going to see examples of this, but I need you guys to kind of like define them first. No, I mean, like, what do you see on the EKG? Right. So Asa said partial damage of the AV node. So you're actually right about that. Good. So Yusuf says the definition, right, is basically 0.2 second PR interval increase. That's it. Right? But look at this. Is there a QRS always following a P? Yes. Right? It's just that the PR interval is increased more than 5 small boxes, more than 0.2 seconds. Okay? All right. Now tell me about second degree heart blocks. Now it gets more serious here. There are Mobitz 1 and Mobitz 2. Forget about this one. This is for all you guys that are going to go into cardiology. I just want to know Mobitz 1 and Mobitz 2. What are those? Good. So as it says, type 1 shows a progressive increase. Progressive increase in what? In PR. And then you drop a QRS. And then you start from the beginning again. Right? Progressive increase in PR. And then boom, you drop another QRS. And that's usually at a fixed time. So, for example, certain ones cause it every third prolongation, some every second, some every fourth. Okay? Well, what's Mobitz type 2 now? All right, this one, I'm going to put exclamation marks here because that's the dangerous one. Right, so the PR interval is fixed, it's fixed, and then boom, all of a sudden, random drop, right? But random, well, hold on, random, but it's that PR interval is fixed, right? There's no widening of the PR interval, okay? When we look for a heart block, we like to go all the way down on the EKG and look at a continuous strip all the way on the bottom. That is the one that makes it easier. Now you can look at any one, but that's the most easy one. Okay? All right, now why did I put exclamation marks here about Mobitz 2? And why did I say this is a more dangerous one? Good. Mary said it, patient needs a pacemaker. Why? That's why. Because it can progress to third degree heart block. Okay? Well, how about first degree and Mobitz 1, second degree? How about those? Am I worried about those two progressing? No, those are benign and you could observe. Okay? Everybody clear about that? I don't have to put a pacemaker in. Mobitz 2 and a complete heart block, that's why I'm circling these two, need pacemaker. Okay? Everybody okay with that? Right. And so a lot of these you have to use atropine, but the bottom line is if they ask what do you need to do to this guy, right, you probably have to put a pacemaker in. Okay? All right, very good. All right, having said all that, all right, tell me what you guys see here. Right, so this is a continuous strip now, the two bottom strips. All right, remember, you got to look at all the 3, 4 things we talked about. If you do the 3, 4 things, it's kind of like like a chip seed, right? You don't look at everything. You look at these things to kind of figure out the problems on the USMLE. Okay, tell me the rate. So rate, okay, 300, 150, 100, right? 75, right? About 60. Okay? Everybody okay with that? About 60. Everybody okay with that? Got to find one that's right on the line. Right? See, I found this one right here on the line almost. And I counted the thick boxes, the 0.2 second boxes. That's what I'm doing. Right? And then here's the second QRS. Right? So the 300, right? 150, 100. I want to make sure I didn't miss anything. Right? 75, 60. Okay? Everybody okay with that? Man, we got to do that. All right, so that's number one. We got the rate at 60. Okay, so now PR interval. What do you guys think? Good. So as I said, and Nathalie said that the PR is prolonged. Oh, it's definitely more than one box, right? one big box, 0.2 seconds. Okay, so that's one. All right, number two, let's make sure that it's stable. All right, looks pretty stable. Right? Everybody see that? Doesn't get longer. Looks about the same. It's almost 0.4 seconds. Almost. Right? So there's no variability in the PR interval. Okay, so that's number two. Number three, does a QRS complex follow every P? All right, here it is. Here it is. Here it is. Here it is. The answer is yes. And does the QRS complex look normal? What's normal? Less than 3 boxes, right? 0.12 seconds. Yep, it looks normal. All right, so then what do we have? We have QRS following every P. So the only abnormality here is that the PR interval, instead of being less than 0.2 seconds, it is almost 0.4. So what is this called? This patient has a first-degree heart block. Okay? Everybody see that? No, it's not sinus bradycardia. So your sinus bradycardia and first-degree heart block are two different things. It's like saying the guy's got, a conjunctivitis with testicular swelling. Two different things. They either got sinus bradycardia. I'm joking a little bit, right? So you guys can remember it. So you either got sinus bradycardia or first-degree heart block. See, the first-degree heart block causes bradycardia, Mary. That's why you can't listen. They're two opposite. They're two different definitions. Okay? Everybody okay with that? Right. So the definition of first-degree heart block is a prolonged PR interval. Okay, what do I do next? Right, you don't need to treat. So what do? I investigate, right? So what do I mean by investigate? I'm trying to find out, why does this person have this block? Right? You tell this patient, okay, you're not going to need it's nothing dangerous, but let's figure out why you got it. Are you taking too much beta blocker? Could you have had an ischemic event? You kind of try to figure it out. Sometimes it's nothing. It's just degeneration of the conduction system. Okay? Right? So the definition of a first degree AV block, very important. Each P wave is conducted to make a QRS. The PR interval is more than 0.2 seconds, but it's always fixed. So listen, you guys have to measure that. Right? So in this patient here, look at this. I measure this. Again, it's almost 0.4 seconds. Right? See that here? Almost. Maybe a little bit less. They're saying 0.32 seconds. But the point is, it's always about the same. Okay? This is a block in the AV node. Something happened to your AV node. It degenerated. Sometimes, they get ischemia. So you got to wonder, does this guy have some kind of ischemic event there? Sometimes it's just degeneration. All right? Don't put a pacemaker in. You just observe and reassure. Okay? But investigate, find out what is going on. Okay? All right. What do you guys think about this case now? Again, go down to the bottom where you have a continuous strip. Good. All right, what is this called? So look at here. Look at the PR interval here. Okay? It gets bigger. It gets bigger. It gets bigger. Right? Boom. You've lost the QRS. See that here? Okay? Again, it gets bigger. It gets bigger here. Right? And if you would follow this, a couple beats later, you would lose another QRS every fifth beat. Okay, what is this called? Second degree. Right? Wegenbach, right? Type 1. Okay, hold on. Let's go back here now. All right. Does the QRS follow every P? Well, here it does. Here it does. Here it does. Here it does. Here, right? You drop one. That's the essence of a second degree heart block. All right, now here's the other one, the other thing that's very important. All right, the PR interval is increased. Yeah, maybe not the first one, but look at the second one. Right here. Look at here. Look at here, right? They're definitely increased. Right? So it continues, right? Every beat it gets larger and larger. Okay? And the third thing that is super important here, because you got to be able to tell this between a more severe type of heart block, like the third degree heart block. Look at the QRS complex, right? Does it look normal? Does it look like less than 0.12? Right? Three small boxes? Yes, it does. All right, check. Right? Why is that important? Because I want to know it's not idioventricular. I want to know that the QRS complexes that are generated follow the normal conduction system. If they were wide, it means that it's idioventricular. Right? Everybody understand that? All right. What do I do next in this person? Right. So ASA says if they're symptomatic, right, you can give them atropine. Right. That's good. Most of them are not. Okay. What don't I have to do? I don't have to put a pacemaker. Everybody agree with that? Okay. And then some of you said correctly, yeah, I got to investigate. Like why? Okay, it could be just degeneration of the conduction system, but sometimes look, there's a cause. Right? I remember one time a young guy came in like this, and we looked for everything. And then, a smart resident of mine says, why don't I check Lyme titers? And his Lyme titers were off the wall. Right? This guy had Lyme disease unbeknownst to them. And this is one manifestation of Lyme disease, Lyme carditis. Right? So my point is, look, you're not going to find everybody with a second degree or first degree heart block having Lyme disease, but you have to investigate. Especially be careful about medication people are taking. Okay? All right, very good. So what is the definition of a Mobitz 1 or Wegenbach? All right, so you must have two consecutive conducted P waves. The most important thing is that the PR interval progresses and prolongs until a P wave is not conducted. QRS is dropped. The block is in the AV node. It is still considered a benign block, right? So here it's even better illustrated, right? You see the PR, you see the PR here, PR is getting bigger, all of a sudden conduction fails right there, right? And if you follow that out, right, you'll see it again and again. Okay, I don't have to put a pacemaker, give them a little atropine if they're symptomatic, and investigate. Okay, everybody okay with that? All right, very good. All right, how about this? Well, this EKG is not a good EKG, right? Because kind of squished, right? But what they're showing you here, this is not a delta wave. No, it's kind of squish, right? So look at here, showing you that the PR interval here is fixed. It's fixed, right? Where did the QRS complex go here? Disappeared, right? Everybody see that? All right, so when we have a fixed PR interval and then you drop a QRS complex, what is this called? This is again second degree heart block. Okay, what type though? Now it's type 2. And this type 2 is dangerous, right? So I got to put a pacemaker in this patient and also have atropine with me, right? Because this can degenerate to a third degree heart block, which is super dangerous. Okay? Now look, remember, PR interval stable, PR interval stable, you drop a QRS. Okay? Everybody okay with that? All right. Look at the QRS complexes. What did you guys notice? Good. Thin and sharp, right? All right. What's the magic number? 3 boxes. Do they look like slimmer than 3 boxes? Yes, they do. So you know they're coming from where? They're not what? Right. They're above the ventricles. They're coming from the normal conduction system. It's supraventricular, not from the ventricles. Ventricles is dangerous. If you can safely say that somebody would have a second degree heart block type 2, you're probably okay with that. The problem is that these blocks are unstable. They degenerate to third degree heart blocks. That's what causes the problem. So they have to be looked at something unstable and that can degenerate to third degree heart block. Okay? All right, Mobitz type 2, right? The PR interval is fixed. Okay? The QRS is dropped. Now the problem here is it's not in the AV node, it's infranodal, right? Probably one of the bundles of His or the bundle branches. That's what makes it a little bit more dangerous here. All right, so look at here. PR interval, right? Stable, stable. What happened here? All right, type 2. Okay, what do I do next? I put a pacemaker. Okay, everybody okay with that? All right, wonderful. All right, complete heart block. All right, let's talk about this. The P waves and the QRS complexes are completely independent. No P waves are conducted. So you got P waves, right, from above the ventricles being generated, but they don't go down to the ventricular levels. There's a block between the atria and the ventricles, right? The conduction system doesn't communicate. All right, now look at this. The QRS complexes are regular. I'll show you that. All right, so if you measure QRS, because one pacemaker usually takes over in the ventricles, that is stable. It's regular. Now what rate is it usually? Because it's idioventricular. So think about, we said your SA node is about 70, 80, right? AV node is a little slower. Idioventricular pacers are in the 40s in the best case scenario. Sometimes they're in the 30s and 20s. That's when you get into trouble, right? So look at this now, right? First of all, what strikes you right away about the QRS complexes? They're wide because the block is such that you have to activate one of your idioventricular pacers. And when you generate such a pacer, when you activate such a pacer, it's a defense mechanism. If these pacers don't pick up, patient dies. All right, you activate those. They, because they're in the ventricles, they don't use the normal conduction system, the fast fibers. So you go through the ventricles. That's why the QRS complex looks wide, because it takes a long time to activate. Right? So look at this. What the definition was saying is, look at this. If I measure QRS, right? Those are regular between them. Right. And Sam pointed something else out. The PP intervals are regular. They just don't communicate with the QRS at all. Right? Everybody see that? So you got P waves, but they don't go down into the ventricle. They don't get conducted. Right? You have two different systems, totally disjointed here. Exactly, like what's going on in our country right now with politics, right? Everybody see that? All right, so a total disconnect between the P waves and the QRS. Okay, now look at this. Measure the QRS, right? All right, so look at this. 300, 150, right? 100. Let's see their pace, right? 75, 60, 50. Ooh, right? You're like in the 30s here, right? Right? Everybody see that? This guy is like, in trouble. That's why you got to put a pacer in this guy. Okay? So a total disconnect between the P waves and the QRS complexes. Please be careful when you see wide QRS complexes, it's a complete heart block. Be careful if they ask you on the USMLE, right? What are the QRS complexes? They're regular. Between themselves, they're regular. They're paced at idioventricular rate, so they're in their 30s, at the best 40s. Usually in the 30s and 20s. Okay? Everybody okay with that? All right. Give them a pacemaker. All right. So this is your cheat sheet, right? So when you guys take the cardiology test, all right? So first degree is fixed and regular. Okay? Mobitz type 1, right, is not fixed and it's irregular. Right? Remember, because every one is increasing. Mobitz type 2 is irregular but fixed. Right? Fixed, drop. Right? And complete heart block, right, is definitely, the PR interval is not fixed. Right? Everybody see that? The QRS complexes are heart regular. Okay? Everybody okay with that? Samuel, I don't know. It takes 50 hours to do the intense prep. All right. Everybody feel comfortable with this stuff, right? This is good stuff. Let's make it easy. Don't make it hard. Okay? You guys know this stuff. All right. Let's stop there. Let's take a 10-minute break and we'll come back, talk a little bit about sinus tachycardia, right? And some other tachyarrhythmias, right? What are the two tachyarrhythmias we got to know? Well, there's more than two, but what are the ones they're going to ask us? Well, no, you guys are going to get every single one right. Guys, do not skip the EKG questions. They may give you 3, 4. You guys are going to get every single one. With every EKG they're going to throw on the USMLE, you will. It's in this lecture. Okay, so Rudy said, Yusuf says SVT. Not so much. So, well, supraventricular tachycardia is okay in general, right? So Samuel says AFib. They're going to ask you guys AFib, A-flutter. Got to know those. Okay? All right, let's take a 10-minute break and come back and we'll talk about that and how to manage that. It's an interesting disease.